Thank you. Welcome to today's meeting of the Health and Social Care Select Committee at the London Borough of Hillingdon. This meeting is being broadcast on the Council's YouTube channel, Hillingdon London. The purpose of this committee is to monitor services provided by health partners in adult social care and review their performance. We also undertake in-depth reviews and witness sessions on specific topics and submit our findings to the decision-making cabinet. We also make recommendations to our health partners as well. My name is Councillor Nick Denys and I'm chair of this committee. Before we start, I have some important housekeeping for everyone present. Please ensure your mobile phones are on silent. We're not expecting a fire drill, so if an alarm goes off, please follow Nikki out of the building. Please keep your microphones muted when you aren't speaking and then unmute to speak. As chair, I will call on those to speak during the meeting. Okay, so we're going to move on to the agenda. Nikki, do we have any apologies for absence? Welcome, Councillor Farley. Declarations of interest. Does anybody have any declarations of interest? Okay. Councillor Martin.
Hi, I'd just like to be clear for small part-time employment at Harefield Hospital on a very occasional basis in the Site Services Department.
Inside information, Derval. Watch out. Anyway, okay, thank you for that. Minutes of the meeting from the 11th of September. Does anybody have any comments on those? Councillor Nelson?
Thank you, Chair. Just want to update for you to give some updates because one of our residents requests that you note what was said by Mr. Curry at the last meeting in regards to the Heathrow Airport putting an offer to Heathrow Airport and it was turned down. So can you please address that?
Thank you very much, Councillor Nelson. And as this resident has emailed all of us on the committee about it, I do have a prepared statement which to make sure I answer their question completely accurately. It should be noted that whilst the minutes are not a verbatim record of the meeting and give a gist of the discussion that took place, a sentence has been missed off at the end of the third paragraph in minute number 25 in the hard copy version of the agenda. The online version of the minutes are correct. The missing sentence reads, Mr. Curry advises that he had spoken to Heathrow Airport about buying the hospice, but that Heathrow has declined. And so obviously that was very useful to get that clarification. Just on the point of the verbatim record and all that sort of stuff, all our meetings are on YouTube, so in a sense the verbatim record is there. So if something is said in the meeting but isn't necessarily covered in the minutes, I'm sure whoever might find that interesting can quote the actual YouTube video anyway, so for that purpose. So that all should be good. Thank you. Are there any other comments on the minutes? No? Are we all good? Everyone happy to agree them? Yeah. Fantastic. Okay, so we now move on to our main item, which is the health. Oh, right. Yeah, sorry. Just to say that everything we discuss tonight will be in public and on YouTube and will be able to be quoted verbatim by anyone who wants to quote them. Right. Okay, let's go on to the health updates. Yes, Councillor Norton?
Chair, I'd like to raise the issue of the late presentation of the paperwork that we receive. As you're aware, lots of us are in jobs and receiving such late presentation doesn't help us because, to be honest, we didn't even have any time to go through any of those and it's papers that's going to be discussed here tonight. So I'm really disappointed in regards to that and to get it be addressed in regards to it too as well. Yeah.
Thank you, Councillor.
Because we have work, we have commitments and work commitments and not given enough time on a committee like this to really go through the paperwork and to formulate questions to the committee. We were unable to do that because of that, so I'd like that to be noted.
Okay, thank you. Before this meeting, Councillor Cawthorne raised a very similar point. Councillor Cawthorne, would you like to share with the committee the point you're raising to me?
Really to endorse what Councillor Nelson has said. We do understand that our partners do face pressures in terms of time. But remember, this is a statutory function that we're fulfilling as a committee on behalf of our residents in the borough. And we are materially hindered by the late arrival of reports, which we're trying to read as we're listening to presentations, and at the same time think about pertinent questions to ask. I'm one of those that like to prepare in advance, and it doesn't help. And given the importance of our role, we would respectfully ask, please, that a reasonable period of notice. You may care to say more about that, Nick. would be really appreciated. Thank you.
Thank you. Yeah, I mean, I feel a bit like a school teacher saying this, but it is, Councillor Nelson and Councillor Corford make absolutely fantastic points. In the sense, I've not been able to read many of today's papers purely because I've been at work. Obviously, we have day jobs. Our rule is that all papers are submitted a week before the meeting so they can be published. In extreme circumstances, when that does not happen, I would ask very strongly there's at least 2 working days for us to be able to read them, because otherwise, as Councillor Nelson has pointed out and Councillor Corford have pointed out, it's really hard for us to read them. There was a suggestion made to me that we should refuse late papers, but I think in terms of our scrutiny function, we want that information, and some of the papers that I got today, when I flicked through them very briefly, looked interesting, so I'd rather get them than not. But please, can we make a very strong effort? So I will leave it there, and hopefully things will go into a better order for future meetings. Okay, great. Right, and very quickly, I just wanted to make a statement about how this meeting's going to work, because obviously everyone here has been here a number of times, and we really appreciate that. We're very lucky to have lots of different deliverers in the area who come and update us, and that's really good. But in order to make sure that the meeting doesn't go on for such a long time that we get tired and can't do a job well, I'm going to introduce a new way of working, which I've shared with the committee, and I think everybody is okay with that. So essentially, each of the presenters will have 5 minutes to present. If at the end of that point you haven't said everything you'd like to say, you can mention the bits, i.e. the headlines of what you might have wanted to talk about, so committee members can know they can jump into that area. Of course, committee members can jump into any area at all. For us committee members, our part of the deal is we won't ask any more than 2 questions per presentation, though I will allow a third question if some of the information given in one of the 2 questions isn't as good as somebody was expecting. So that's how we will operate during this meeting. So hopefully we can still have a very good informative meeting and do it within a time frame where we're still fresh and able to scrutinise very well. Okay, brilliant. Everyone happy with all that? Yeah, good stuff. Okay, so we're ready to start. So first, Jason Sees, Deputy Chief Executive of Hillingdon Hospital. Thank you very much.
Can you hear me all right? Yes. Yep. Thank you, Chair. So just on terms of good governance, I'd like to say Hillingdon did submit its papers in time. It's like saying teacher. But on poor governance, apologies, I'm going to leave my phone on. I'm on call, so it shouldn't go off, but if it does go off, please don't tell me off. Right, I'm just going to whiz through the headlines in terms of just an overview on the headlines, the performance, CQC and redevelopment. So if it all works through. Can everybody see screen from one or the other angle? So in terms of Hillingdon Hospital, just a recap, it's a very sort of busy, what's called District General Hospital. So emergency and urgent care, busy as ever. Broadly last year, so this was our 23-24 figures, the 4-hour waiting time target was, I think, 76% last year, and we did 78.4%. Elective care, we broadly were delivering above plan. Outpatients, very busy as ever. Reasonably busy and relatively well-sized maternity departments, so just over 4,000 births. And key bits on the money, just in terms of our savings plans, but also we were in sort of putting quite a lot of investment in our buildings, and that's related to the redevelopment, which I'll touch on in a second. So just in terms of headlines, from a patient perspective, when you come into your local hospital, what do you sort of require? You see either unplanned care, which is almost where you come in through urgent and emergency care, or planned care, which is referred to as elective care, and then you've got the cancer and diagnostics element with it as well. Broadly at the moment on elective care, we're pretty much on plan, and when we look across the acute provider collaborative in North West London, so we're an acute provider collaborative with Imperial College Healthcare, London North West Hospitals and Chelsea and Westminster. Comparatively, our elective performance is pretty good actually. So elective care sort of going well. Cancer and diagnostics, work to do on some of the diagnostic standards, and a piece on cancer that, as ever, our numbers, because we have relatively small numbers, if we don't make sure every patient is treated in time, it can fluctuate our percentages. So key focus there. The one probably from a patient perspective that we're really focused on is the urgent and emergency care element. So we're very busy. The key element of how it's all sort of defined in terms of A&E performance. So in terms of that 4-hour standard, you have overall sort of walk-in attendances, everybody sort of aggregated together. The sort of more serious treatment in A&E is called type 1 performance, so people coming in ambulances predominantly, and that's a key area of focus for us at the moment to make sure that we're delivering the service our patients deserve. But in the context, I mean, looking at London Ambulance Service colleagues, it is exceptionally busy at the moment. We are in, if I get my months right, October, and it's feeling like, I think, it's feeling like January almost now, isn't it? So, from a hospital perspective, our main regulator for quality of care is the Care Quality Commission, and in terms of their sort of oversight of Hillingdon hospitals, so from a Hillingdon Hospital and Mount Vernon perspective, they inspected Hillingdon Hospital in July, they inspected Mount Vernon Hospital in August, and they also do a review which is called a well-led review, and we had that in September as well, and it's just because the number of interviews almost, that's just sort of tailing into October as well. And so the outcome of that will be hospital trusts have an overall rating, and this will result in us having an updated overall rating, because when you go on the CQC website at the moment, our rating sort of dates back to, I think, probably 2018, so it's quite out of date. So huge amount of work going on with them in terms of ensuring that everything that they've asked that we're delivering on. The other one, just to update, is on our redevelopment. So over the last 4 years, and as ever say thank you to all colleagues around the table, because it's very much a joint effort, the redevelopment has really been motoring. So the key bit for us is about our enabling and decamp programme. So along the west side of our current site, of us clearing that. So huge amount of work already undertaken. So when you go around the Hillingdon site, there's two sort of biggish buildings around the back, referred to as Modular North, Modular South. So we've been decanting services into them. We're currently just started on the first building, which will provide adult audiology, haematology and education and training. We're moving some of our clinical admin there. We're just finalising the plans for the Tudor Centre, which is where the education and training centre is, so that's one of the other areas that we'll be demolishing on the west side. The other side about the west side is we've got car parking there, so we're sort of finalising the off-site temporary car park, and also utility diversions. So from a hospital perspective, they use quite a lot of power, so we're just sort of putting in all the routes and substations around, making sure that we've got the power for the new hospital. So
Jason, sorry, we've come to the 5 minutes.
Oh, sorry, I feel like I'm in an interview.
That's all right.
Right, so I'll quickly, sorry, Chair.
That's okay.
Just summarise of, that's just in the context of, we had obviously a general election this year. The new government announced on 29th of July they will be reviewing the new hospitals programme. From our perspective, again, a huge thank you to everybody for everybody's support. The expectation that end of October the Chancellor will make an announcement.
So I've actually got my question. I'm only going to ask you one question to be part of the new discipline. Was actually going to be on that. Obviously, things are going or have been going certainly very well, and you've reported to us a lot about what's happening with the hospital rebuild and how the hospital have been making sure they're front of the queue and organised and ready and ticking all the boxes. And the council and others have been helping things like planning and all that sort of thing. So, in terms of the review obviously is a bit unsettling because we all know how much we need that hospital. If anyone who's been to the hospital will go, great people, great service, but these buildings are tough to work in, especially when you look at the problems of an A&E, for example. What's the pitch? What's the pitch that you've made to the review team to say, look, we must get the sort of firing gun going on this again?
So, who could I plagiarise? I think the current Secretary of State for Health and Social Care, Wes Streeting, when he visited, I think back in 2023, when he was interviewed on television, really starkly outlined how poor our estate was, and maybe misquote him but I think he said it's one of the worst estates he's ever seen in the country for an NHS hospital, and as part of that pledged that if Labour did indeed come into power, that the new Hillingdon hospital would be built in the first term of a Labour government. So it is very stark for everybody who's been around our hospital. It has to be rebuilt.
A very simple, powerful message. Thank you. Councillor Chandel.
Thank you, Chair. Jason, just a very quick summary if possible. You said you're very busy, unexpectedly busy, so what kind of cases are coming in to A&E? Because I was hoping that with the pharmacists doing a lot more and the health hubs, that it would alleviate the pressure a little bit for you.
Thank you. So, I think, not to sort of get, the whole of London is just really busy at the moment. If we look about how the ambulance is conveyancing Monday night, it was very, I think the busiest night since New Year's.
I mean, as this is a wider question, a very good question, I'm happy for others to come in who want to talk about that.
Thank you. Just also to alleviate some of my 5-minute pressure there, I'm going to steal some of your time, Jason. I think that's
surely you guys are used to time pressure,
and that's how we get around it. We borrow other people's time. I think it's a really key point what Jason's saying here, and one of the part of my report was to highlight actually the increase of the higher acuity calls. So our Cat 1 calls are the most seriously ill, which does take a lot of resources from the hospital as well, has gone up. The same period this year from last year has gone up 13%. We're talking thousands of calls, so the population's gone up, and the acuity of the patient's illnesses has gone up, and that takes a huge amount of time from the hospital when we're rushing in, because it isn't just one nurse we're handing over to, we're requiring a whole team to come down, and we do appreciate our impact, but these are the calls that we're presented with.
Dr. Ritu Prasad is sort of the person here representing or the GP Confederation. I mean, is this something that you've been noticing or your colleagues have been noticing?
That's correct. I mean, it's an aging population that we're dealing with, multi-morbidity. So any person that's coming into general practice, we have 10 minutes, and that 10 minutes is really not enough as well. And then you're dealing with the acute problems as well. So we are seeing that, and they are genuinely sick people, so that you can't, even with your resources that we've got, care connection teams and rapid response teams and the community services, you're unable to keep them at home, a lot of them.
Keith Spencer, you want to come in as well?
Apologies to put some numbers to it from an end-to-end pathway point of view. So over the last year, the absolute number of people who've gone to ED has fallen by 8%. But the conversion rate, which is the amount of people who subsequently get admitted to hospital once they've arrived at ED, has risen from about 25 to around 40-45%. So numbers down, but actually the acuity has gone up. So we have commissioned a piece of work. So I chair the Emergency Care Board for Hillingdon. We've commissioned a piece of work from Brunel to actually look at the acuity, what's happening with patients who are coming to THH and to ED department. Are they iller? And if so, why? So we can try and understand just the root cause of this, really.
Thank you. And when that's done, could that be shared with Nikki so she could share it with us? Because I think it's a really interesting question, isn't it? What's going on there? Thank you.
By all means, Chair.
Councillor Chandel, do you have another question?
No, Chair. Keith actually answered my next question, which was going to be, what is the root cause, and you're looking into that, so thank you very much.
Councillor Nelson.
Thank you, Chairman. My question to you, Jason, is any waiting? And I'm giving you a personal experience of myself. I fell and hurt my feet about 3 weeks ago, and I stood in A&E for 9 hours before I was seen to. 9 hours. So if you guys are going to look at the different aspects of why people are coming in, why so many? Obviously, the GP side of things doesn't seem to be working, and it's my observation from sitting in A&E and looking at the people coming. Obviously, we can tell how individuals feel and what their circumstances are, but that area was so packed with people. The staff themselves was overworked. The ambulance crew was sitting in the passage with elderly people, with very ill people sitting on stretchers in the passage to be seen to. So as much as the QCC has done their report, obviously this 78.4%, you said that you were at that target. For me, in the experience to me, it doesn't look like that. So can you address that for me, please?
Jason, yeah.
Yes, so I think you're absolutely correct. So if you look at, that was our figure for the end of the last financial year. So for us, it's 1st of April through to 31st of March. For this year, we are currently below the target, but as Keith has referred to, we've got a number of improvement initiatives, because absolutely, from what you said and others are telling us as well, we must improve how we're treating people, because it's just the sheer volume of people. We just need to make sure that we see them on time.
Do you have a second question, Councillor Nelson?
I do. Thank you for that. In regards to cancer service and diagnostic, I'll give you a star for that. Personal experience as well. After seeing my GP, in less than 24 hours, I was able to get an appointment and be diagnosed. So that part is working very well. So I just want to bring that to your attention. Opportunities for improvement and forward work, including the implementation of integrated therapy team. What's happening with the schools and the therapy services?
Is that one for you, Keith, more?
Yeah. I have to confess, I'm not quite sure, Councillor. Just could you be more specific in terms of the schools and therapy services? What in particular?
More specific, there is one of the schools in the north of the borough that is closing one of the services that's being provided, and that is stating that the therapy services, the teachers are unable to have therapy service for the schools. So I just wanted to have some clarification of that, because that is not, that's something that is very concerning to us.
So, Claire from CNWL, you've put your hand up, so are you able to help us out?
Can indeed. So CNWL are working with the local authority and with the ICB in order to address this specific issue with the school therapies. We've got a collaborative agreement with our local authority that we're working through, and we're looking at working specifically with this school, and we've got work stream immediately addressing that situation with that school and the ICB around funding and ongoing therapy.
Could I suggest that, Councillor Nelson, if you want more information on this school, contact Nikki about that, and Nikki can then ask Claire for some more details, so you can get some more details on that particular case.
I drop it in before the time, actually, so on item B, which the NWL will be coming back to us on.
Will.
So
okay,
I'm hoping that I'll be able to rephrase that in the right way.
Yes, your two questions will start again at that point, so that's good. I can see how these rules are going to work, but never mind. Right, okay, Councillor Cawthorne.
Yeah, I've got two. I'll try and keep them brief. Okay, the first one relates to what's been said about the people turning up in A&E and the numbers going down a bit, but the conversion rate going up quite significantly. You talked about a piece of work that was being commissioned around that to understand that a little bit more fully. Would I take it that part of that is looking at whether people are turning up to the hospital as a place of last resort, where they might reasonably have been expected to be supported elsewhere within the sort of wider health infrastructure piece, pharmacies, GPs? I mean, is that something you're looking at as part of this?
Yeah, Keith, if you want to answer, go for it.
So Claire and myself and Ritty spend most days talking about these particular issues. So that's exactly what we'll look. That's exactly what the audit looks at, is whether there are what we call alternative pathways that people could have looked at. What we know from the data, and this was an issue Claire and I were discussing today. We know that after 5 o'clock in the evening and at weekends, patients of lower acuity, more patients of lower acuity, come to the ED department. And what we're inferring from that is that that's due to the availability of other services, particularly people over the age of 65. The number of people with lower acuity jumps by 15 percentage points at weekends.
Okay, my other question related to the CQC inspection. So English language is a wonderful thing, isn't it, really? And I suppose part of our job is to navigate what in fact you're telling us. We're aware of the 18 obviously report, which wasn't a good one, to put it mildly. We've been kept informed to an extent of what's been happening since then. And I just wonder whether the concerns raised by CQC this time round for the well-led report in any way materially impact the trajectory of where the hospital are going in terms of improving the CQC view of things, if I can put it that way. Does that make sense? Thank you.
I mean, a very good question. So in terms of the Care Quality Commission's well-led approach, they've revised their approach. So we're, I think, one of the first NHS trusts to go through the process. In terms of that, our understanding is that, so how the CQC work in terms of that sort of one-word overview, outstanding, good, requires improvement, or inadequate. And what we will have in a report to be confirmed when we will receive that is a revised overall headline. I think if you look at the amount of work our staff have put in terms of all the preparation, being quite sort of open but quite proud actually of some of the achievements that they've made since 2018. I wouldn't like to second guess or propose what the CQC might rate us, but hopefully that they would really have taken on board all the improvements that have been made since 2018.
Thank you. Councillor Burles.
Thank you, Chair. Funny enough, Councillor Caulfield stole my question.
Efficiency, fantastic.
CQC. Are there any indications coming out of it already at all? Do we know what mark we're going to get this time at all?
So to give you a sort of honest answer, with the Care Quality Commission, of until you get that draft report, you don't know. So apologies, until we get that back from them, we can't. They don't give us any insight ahead of the report being sent to us in draft form.
Okay, thank you.
Councillor Martin.
It's just a numbers question, really. In point 4, with the hospital redevelopment plan, you said a number of wards along the annex corridor have been closed off. With 113% improvement on the elective activity and the pressures from the ambulance service and all of the people coming in, I think a 13% rise that was mentioned. How are you managing with a reduced number of wards and beds, and what is the numbers of that reduction at Hillingdon Hospital?
So in terms of bed numbers, the piece where we've been very fortunate, so in terms of that enabling and decant funding that we've got from our colleagues at the centre, if you look at the number of beds that have been re-provided in those modular north and modular south buildings, are more beds than are currently in the annex corridors. So from that perspective, there is assurance that through the enabling decant, our beds aren't going down. Probably the point you raised, though, is well made, is that not just at Hillingdon hospitals, but you see at a number of trusts, is that there used to be a cycle of hospitals having what's almost called sort of winter beds, and then they would then close during the summer. The piece for us is that we've still got our winter beds open. That's not dissimilar to a number of other trusts, particularly across London, but the piece is that are we now looking at a new cycle where winter beds aren't closed? So that's the piece about whole system working and your question about how do we make sure that people are using the right services and going to the right place, because there's always a risk of if we're not careful, hospitals will just get busier and busier and busier and bigger and bigger and bigger. And actually the real strength of our redevelopment planning is how all our partners come together about the out-of-hospital model and the hospital model. Because if we don't have the same absolute drive and development of our out-of-hospital model, there will always be an issue with the size of the hospital. So, dare I say it, Keith is presenting on Friday to Hillingdon Health and Care Partners the place-based transformation strategy, because we need to look at all the initiatives and at what pace we need to go, because that has a absolute correlation with how many beds there are in the hospital. So it's coming together, but it's, as people have discussed, it is exceptionally busy at the moment.
Excellent. Councillor Farley.
Thank you, Chair. First I want to say thank you to all the hospital staff. You know, we commend them, very hard working. I want to sort of tag on the end of Councillor Cawthorne's question. I'm not aware of the report that he was referring to, but the concerns are not spelled out here. This is on page 17 of Part A pack. I want to know exactly what these concerns were. You know, they were being addressed, but could you spell out precisely what these concerns were that were raised? Thank you.
So in terms of if I work back, so just on the question of the well-led, there's no feedback as such yet. The Mount Vernon piece, no feedback as such. When they visited the Hillingdon, there were sort of areas around emergency and urgent care, so picking up on the question earlier about people waiting, just to make sure that where people are waiting, that the observations were in place and everybody is having clear oversight of clinical need. There was obviously areas where they've highlighted very poor estate and how that affected our care, but we're as much as we can making sure that we do provide the best services we can for patients within the current estate. There was a piece just around our surgical daycare model, which we've addressed, and the other area was just about making sure that all our staff are adhering to infection and prevention and control practices.
Councillor Farley, do you have a second question?
I do, thank you, Chair.
Great.
One thing I'd like to pick up on, which is not mentioned in the report or the slides, apart from a reference to the number of staff that you've got, which says permanent staff. I don't know how much that is doctors, what's nurses, what's porters, what's ancillary staff. I mean, that would be interesting to know what proportions. But I'm also curious about the care of the staff at the hospital. You know, they all suffered through COVID, you know, mental health issues. I'm curious to know what the hospital is doing to support and has been doing to support the staff. Overwork, long hours. So I'd like to sort of know a bit around that aspect of staff care. If you've got that, thank you.
So from a trust perspective, we have what's referred to as our people strategy and our people plan. I mean, absolutely. In terms of healthcare, it is essentially, I know we're focused in some part about the building, but it is a people business. And so the key element, you're absolutely right pointing out, people came out of COVID very tired and worn out. And so from our perspective, that people strategy is about how we're really supporting and really making sure that on a day-to-day basis, our staff are absolutely able to get on and do their jobs. So I think we've made huge strides forward with our people strategy and people plan. The NHS has a staff survey every year, and if you look comparatively of our staff survey results last year compared to when it was COVID and previously, I mean, significant improvements were shown right across the board about how our staff are feeling at working at Hillingdon. I think the key element that we keep striving forward for is one of the big things we can do is just make sure that we have as many substantive staff as possible. So that's the key piece that we keep driving forward, because from a staff perspective, but also how everybody sort of works in a department, if we've got really good, high substantive workforce, that just allows people to sort of get on with their jobs a lot easier. So that is an element, again, in terms of our recruitment and retention, which we're really driving forward as well.
Thank you, Jason, and thank you for giving that report and answering our questions. Next, we're going to move on to Claire Eves from CNWL.
Thank you. Okay, so I'm Claire Eves. I'm representing Vanessa Odlin for CNWL, and just wanted to give you an update on what CNWL has been doing in Hillingdon for the last 6 months. And as you can see from the report, we deliver a high number of services. So I will give you a brief overview of what we've been doing in our physical health service. We've been working extensively with our primary care colleagues in delivering our neighbourhoods and how we realign our nursing services and then our therapy services into our neighbourhoods, and working with our GP colleagues to deliver a more robust community offer. And we also work very closely with our hospital, as we've alluded to, as healthcare partners around discharge and flow, and how we think about our discharge to assess model and our home first, and how we make sure that patients, when they're medically optimised, are moving out of the hospital into the care that they've been identified. Also, we deliver our rapid response service, which is also known as our urgent care response, and I would like to just direct you to the past 2 years we've been meeting our target of a 2-hour response. So we take referrals from across community services, GPs and our LAS colleagues, and we respond to the patients in their own home to prevent hospital admissions, helping the front door and avoiding those admissions. And as you can see, we have increased our compliance and our performance over the last 2 years. CNWL also running, just so you're aware, a community service month during the month of November, which will provide us an opportunity to showcase the work that we do in community. There's a big focus on acute services, but it's around what those community services doing to support the system, and it will be delivered, and dates and venues will be circulated and communicated widely. Moving on to our children's services, as I mentioned earlier, we're working with our local authority on a transformation and a collaborative approach to delivering our services in family hubs and delivering stronger family services. And this collaboration work is to really look at our resources. Resources are, obviously impacted, and so we're looking at innovative ways of working to improve service delivery for our families and our young children. Just so you're aware that earlier in the year, NHS England did a review of our childhood IMS across London, and that service was awarded to VAC UK, and we've been working through the summer to ensure that we hand the childhood IMS service safely to VAC UK, and that occurred on the 1st of September. Adult mental health. So the system has seen an increase in mental health patients presenting to the services, especially at the front door of Hillingdon Hospital. And we've got a number of initiatives in place, which I have highlighted there, including Hillingdon Lighthouse, which is located at the front end of A&E. It's a purpose-built area where we can take our mental health patients and treat them and assess them securely in that space. And as you can see, we have gone to a 24/7 model, and where you can see in that graph, we've done a step change, and you can see that the number of patients going through that lighthouse and the number of 12-hour breaches has significantly decreased. We've also got the crisis house, and that is known as the retreat, and we have had confirmation that we have got full year funding to continue with that. And there's a meeting at North West London next week to look at also the ongoing funding of the lighthouse, and we're really hopeful with that data that we will continue to be able to deliver that and continue with the funding. The Cove Cafe was opened in March, and that's a really safe space for people that have got early diagnosis to actually who've got anxieties to come together and feel supported, and we've had some excellent feedback, and we're really pushing for more patients to go through that service. We also look at high intensity users and our mental health crisis assessment centre, which is based at St Charles, but we do take Hillingdon patients that present in A&E at Hillingdon. So we're looking at further initiatives this winter around how we can address the mental health patients turning up at Hillingdon Hospital, but also at the back end around how we can extend our physical integrated discharge team to look and take mental health patients to improve flow. Moving on to addictions and recovery, the main area of focus in ARCH is the mobilisation of the new Hillingdon Substance Misuse and Stop Smoking service that was awarded to CNWL back in the summer. And as you can see, we've got some really good, we've built some strong service reputation and performance. We've got service user board engagement and a launch of an electronic prescribing system.
Thanks, Claire. We've come to the 5 minutes. I mean, is there anything else really burning you want to mention before we go into questions?
Okay, so I think just our CAMS work that we're doing around early intervention, and the CAMS offer has been expanded, and that has increased the number of people going through but reduced the waiting list for our young children.
Fantastic, thank you. Is the Heathrow Villages Wellbeing Bus report one for you or one for Keith? Or is it for both of you? I've got a question. I just want to know if you're the best person to ask, or if I wait for Keith later.
I don't mind.
Are you happy to take a question?
I can, indeed. I
wasn't
expecting
and of
that.
course, Keith can jump in. Well, it's something that we've been interested in, and I got the report earlier today, and I hadn't seen it before. So, but I'll ask the question, and whoever feels able to answer it can jump in. So obviously I got I got it today, and I managed to read it on the tube actually on the way out. That's why I chose to read on the tube on the way out. I suppose I'm going to make a comment, and then I'm going to ask a question. And my comment from reading this report is that while the intention to do something to improve health services in Hillingdon, in the Heathrow Villages, is very important, it seemed like this initiative was never going to be overly successful from the start, because the design of it seems to have had a lot of holes which, I think maybe could have been looked at before it even started. For example, the bus wasn't fitted out in a way that was conducive to to operate such services. Parking in places was a problem, all these sort of things. So having read the report, I was a bit like, okay, it didn't seem to work, but I felt like that actually, it just didn't, it was never going to work actually. So that's my sort of observation. But I mean, brilliant to try stuff, and that's really important. So I don't want to be sort of overly negative about that. But so what's going to happen next in terms of trying to improve the sort of frontline health services that those in Heathrow Villages get, and what have you guys learned, and what are you going to be doing about it next? Is my sort of very broad question. Sorry?
Chair, before they give an answer to that, We haven't had an opportunity to even look or read at the report, so we were unable to prepare any questions or anything to it. So even though they may respond to it, I would like us to come back to it.
Okay, so fair enough. I mean, I think that's a very good... The report was sent to us today, and I did read it on the tube, which is why I've happened to read it, but Councillor Nelson is completely correct. Probably other members on the committee haven't read it, and it is an important matter for us. So I think at another meeting we'll raise it more in general. But just if you could answer my question, and then we'll, in more in depth, look at our work programme and deal with it in another meeting. So.
Okay. Firstly, apologies for the late circulation. Just so that you know, yes, there were limitations to the model that was rolled out, and we very quickly recognised that there were limitations. They were taken on board, and I will hand over to Keith because you have taken some of this work forward in the local constituency.
So, Chair, what we did is when we had the report and we sat down with local community members and talked through the report, and I think the conclusion that we came to, and I think it was genuinely a collective conclusion, although I'm sure residents will remind me if it's not, that actually trying to find a fixed location within the Heathrow villages was probably more preferable and easier to do. What I then did, working with colleagues with residents out there, is to meet with Heathrow, is to look at what the options were for a fixed site in there. We focused in on 45 Holloway Road. I'm going out to meet the residents tomorrow with Councillor Palmer. We'll be taking plans for that fixed site out there and to talk through what the next steps are going may well be. So perhaps the best thing to do, picking up Councillor Nelson's point, either happy at this meeting or maybe at the next meeting, to have a more detailed discussion about that. But I'm in your hands.
Okay, well, thanks. I mean, our next meeting is on the 12th of November, and we're going to discuss our work programme later. But, I mean, I'm very open to the idea that we have an item specifically on this, and so we've got a chance to read the report and hear about maybe some of the developments that are happening, but we'll obviously confirm later. Councillor Nelson. And
let it be noted that we are unable to comment because I haven't seen the report.
That is noted, thank you. Councillor Cawthorne.
Okay, a couple of questions from me, if I may. The first relates to CAMS, which we've discussed at length in the past, but of course it's always of interest to us. I'm interested in the early intervention offer and COOF, which we've been hearing about for a while. I hear good things about it, but I'm just interested in to what extent we are able to validate the outcomes of that, i.e. the number of people using that service, how many of them find that it's adequate for their needs and helps them on to their onward journey, or indeed how many are still needing to access clinical services. Is it a sort of a stopgap because it's all that's available, it's better than nothing, or actually is it improving outcomes in a way that means that people aren't running headlong into clinical services? That's my first question.
Thank you. Yes. So on initial review of the data, it is having an impact, and we can bring something back in more detail if that's of use, and that I think it's a part of a package rather than just a standalone service. So I think that's something that it's something that doesn't just work on its own. It works as part of the offers that and the interventions that we offer in CAMS.
Thank you. I mean, we'd certainly like some more information about the effectiveness of that.
I was just going to say that. Thank you. Yeah, be useful to know that. And my second question is around something you said earlier relating to children's services and the hubs. You talked about developing innovative ways of service delivery. I wondered if you could bring that to life for us a little bit in terms of how services are starting to look and feel different for service users. Thanks.
Okay, thank you. So yes, we're working really closely with our local authority lead around our early help with children's and their obesity, how they're starting in their schools, making sure they're school ready, and working in our family hubs around how we and where we deliver our early help services. So we're catching them earlier and working with our health visitors and our family hubs in order to make sure that we're delivering a family service that is earlier, and we're capturing them earlier, because what we're seeing is children going into schools, they're not school ready, and actually it's taking a lot more service input into some of that.
Thank you. Councillor Bells.
Thank you, Chair. I'm a little bit concerned with the paragraph about the crisis house. It says whether they're going to continue with it. And also, one of the big things I'm always interested in is not so much the numbers, but measuring outcomes. And I wonder, I see you've been doing it with the Cove. It seems to be doing it with the Cove, where there's 94% of people reporting better outcomes, but there's nothing for the crisis house. We have got some graphs, but they're hard to read in black and white. I can't read them, but I'm a little bit concerned by whether we're going to whether to continue with the retreats. It does concern me.
You turned it off. Okay, so yeah, that alludes to the meeting we've got at North West London ICB next week, and where we're presenting the data in more detail around the length of stays, the number of patients that are going through the crisis house, and actually the complexities that we're moving away from A&E and how we're managing those. So we're looking at really how we can present that data back to the ICB to assure that we'll get ongoing funding for that. And so we're hopeful that that is a discussion that we will be putting forward.
So I'm going to use my second question as a follow-up question to Councillor Bell's question, because I think it's a very good question. It's something that I was thinking about. Then you can come in with your other question. Yeah. Because I was thinking of this as well, as to ask this. I mean, one of the things that definitely doesn't come out in the report, which I think is really of interest to us, is are these services reaching as many people as they should in order to help people as early as possible? It's a very big, broad question, but in the past I know that with these services, one of the problems has been getting them, people referred to them, people understanding, and people using them. Now, I mean, I think that there's something of real great interest to us, because I've visited the Cove and it was really good, but it's a space I think I want to make sure it's being used really well in order to do what it does. So is that information captured, and if it is, could you share it with us?
Yes, that work is definitely captured, and I've seen that there was low uptake. That has increased. We have widened our criteria to ensure that we're taking complex patients, and more work has been done to really focus on not only some of these services that we're looking at here, but before patients get into crisis. So it's looking at our community hubs and the work that they're doing in order to really capture them and hold them in the community before their crisis happens. What also we're finding is that it's not just Hillingdon residents going to Hillingdon A&E, it's outside residents. So we've had people from Bournemouth turning up to Hillingdon A&E, and what's the understanding, what actually has brought them there. And also we have got the Heathrow Airport, where we see a number of patients coming through. So there is a transformation piece of work, a deep dive into what we can do further, obviously to address the crisis, but also what we're doing beforehand.
Okay, my request, which is for Nikki to note, is that when we have our next health updates in 6 months' time, I would like quite a lot of your paper to actually talk about that and how that's working, because I think that's such a crucial thing that we want to know more details about. Is the service being used well, and is it alleviating things? So Nikki will note it, she'll remind you nearer the time about that. So thank you. Keith wants to come in, and I'll come back to you, Councillor Bell. So, okay, Keith, you want to come in on this point, do you?
I think we have a growing problem in terms of mental health, and it had nothing to do with the services that price C&L, but there is a growing problem across North West London and a growing problem in Hillingdon, which I think scrutiny has to be aware of. If we just take ED as a litmus test of that, we're now seeing in any one day 4 to 9 people going to ED departments in some form of crisis in terms of mental health. That's just symptomatic, I think, of other challenges that are taking place elsewhere. And I think from a Hillingdon Health and Care Partners point of view, don't want to prejudge the outcome of either Friday's discussion or next week's discussion on strategy, but I think that mental health will become an increasing priority for Hillingdon Health and Care Partners. And it's nothing to do with the quality of the services that are being provided. I think that there's a growing incidence of people with mental health challenges that we do need to be aware of and focused on. I think primary care notice it, St. very well notice it, the hospital certainly notice it, and I think we do need to rethink our offer in the light of that.
Okay. Thank you. Councillor Bells.
Yeah, thank you, Chair. Just on the arch, I noticed you're saying there's been you call it a new arch service. Me and Councillor Nelson visited the arch on its open day last year, and we were very impressed with the services provided there and then. Has there been a drastic change? Because it says a new arch service, and I'm reading the bullet points down, and there's some sort of quite fundamental changes been happening. Can you just expand on them a little bit for us, please?
So, no, I can't, I'm afraid. There's no point in me trying to say any more detail than that's written in the report. I can take any questions back, so there's no point in me trying to allude to the information that I don't have.
But you will be able to provide an answer in writing to us on that point. Yeah, thank you very much. Councillor Nelson.
Thank you, Chairman. I'm coming back to the issue that I raised early on in the Hillingdon report regarding the infant school in Ruislip. The staff was notified that the school will be closing, and the therapist service, which is funded by the NHS, will be affected. And I just want to ask a question. What pressure will this put on the school, as currently the school has been trying to do that? Sorry. The course teachers will have to connect directly with the NHS. So can you tell me what pressure will this put on them, on the school itself? And the school has been trying to do that, but hasn't had a speech therapist since May. Can you elaborate on that, please?
Yeah, I can. So there has been an issue around the funding of the speech and language therapists going into the school, and also resourcing that post. We have escalated this to the ICB. We have written a response in conjunction with the ICB to that school, and we are working immediately to find a resolution to that situation. And I can provide a further update next time, but I'm saying that there's work in progress because we understand the seriousness of not providing speech and language therapy to our children in that school.
Thank you. Councillor Nelson. Well, I'll let you have two more questions, okay?
I'm pleased to hear that, but where it concerns the kids with therapy services and camps, we're not getting any clear direction in regards to some of the services that's happening and people not being able to access the services. And this is another part of it. So, as Nikki said, can we have an in-depth report in regards to where you're at with this? Because this is something keep coming over and over and over again to this committee, and we're still not getting clear directions for the youths in our borough, what's happening with them. But not only in the borough alone, our youth that's really going through some terrible provision in regards to their needs. So I'd like you to really give us more in depth, because every time we just get in a little bit, but we still can't come to a really good decision in where we're at really with NWL in regards to the service provision. The other question I have is on it's on the arch, and Tony covered most of it, but one of the things that we have noticed here in regards to that is they have now a 7-day services, which is very good, because it used to be a Monday to Friday service and not a 7-day service. So that's something that I think that has improved, but it would be good for us to know how that service is being updated and what is so special about the different bits that they're doing well. I think they're doing well for the service that they provide. But a more in-depth report on that.
Yep. So basically nodding to those two more in-depth reports.
Absolutely.
And further questions that people might have off them, we can do that as correspondence if necessary before the next meeting.
Thank you, Councillor.
Okay, thank you. Oh, Dr. Ritu Prasad, you want to come in on that?
So can I just feedback regarding art from the primary care perspective? So what they've also changed is they're doing a lot of physical health assessments, especially with a prevention of liver damage, and they're doing fibroscans to assess people who may be at risk of liver damage. So that's an aspect that's really improved, and patients are seeing the benefit of that. And the 7-day service has helped because a lot of people who are in crisis during the weekend, now they're getting that help. So that's what we see from a primary care perspective.
Thank you. Thank you.
Thank you so much for that, because that's one of the things that has been displayed to us, because they have everything under one roof, so the users don't have to go to different places. So the 7 days is very important. Thank you.
Excellent. When we get the report, we can sort of ask some more questions, so thank you for that, Councillor Nelson. Okay, I'm going to move on now to Derville Russell from Harefield Hospital. Derville.
Give you 5 minutes. I'll try and be brief.
Everyone's been excellent so far, so congratulations to us.
I'll try not break that trend then, Chair. Okay, so want to talk a little bit about elective activity. You probably saw in the news that several organisations in South East London, which include Guy's and St Thomas's and King's, and of course Brompton and Harefield hospitals have been part of Guy's and St Thomas's for a few years now, that our pathology services were victim to a cyber attack, which basically resulted in us having to isolate our pathology systems from our main patient administration system, EPIC. The result of that is that if we take, for example, administering blood and blood transfusions, all of that had to be done manually instead of electronically, which is like a massive step backwards in terms of the amount of time it takes to prepare blood and do the safety checks and administer blood. So that resulted in a big drop in elective activity. I would say it was most marked in the first 2 to 3 weeks, and then it was a period of recovery. But to give you an example, there were 3-4 meetings a day where clinicians had to present their cases that they were planning to operate on in the next week in order to establish was there enough matched blood for people to be able to proceed with those procedures. During that time, we had to use Group O blood, which is more of a general blood group rather than cross-matching A, B blood. That affected all the sites, but as I said, we found workarounds, and actually through sort of July and August, that did improve. Everything was reconnected finally on the 22nd of September because they had to rebuild those systems and test them before connecting them back to the patient administration system, EPIC. In terms of our waiting list, as a result of this, we haven't seen as much drop in the numbers as we would have liked. And we still are very closely monitoring our patients using the Autis platform, which I believe I've spoken to you before, which detects patients that may be deteriorating or any concerns they have, and that flags it to the clinician, who can contact the patient, assess how they are, and bring them in or escalate them as needs be. We are at the moment actually working with Autis, that company, to try and integrate that into the EPIC system, which would be a great step forwards for not just surgery, but for all specialties that have got longer waiting lists than they would like at the moment. In terms of diagnostics, there's a lot of focus in all hospitals about diagnostics and trying to get patients their key diagnostics within 6 weeks, and we're measured closely about it. Some of our specialties, for example, CT, MRI, ultrasound, we're meeting it without any problem at all, and actually we're providing a lot of support to hospitals in North West London, helping them with their diagnostics in that area as well. The two that we've struggled with across all our sites have been echo and sleep studies. We've done a lot of work with echo, both on looking at modifying and being more innovative with our workforce. We also have restructured our echo department, moved people that aren't clinical out of the department so we can create more clinical space. So we are estimating that within the next 3 months, echo will no longer be a problem, which is great. Sleep studies across all the sites, so St Thomas's, Brompton and Harefield are struggling. And that's for a number of reasons. It's partly because of the build-up of patients. It's partly because of patient compliance, particularly with returning equipment, which we're working on as well. Part of it, we do believe, though, is that when we moved over to Epic, there have been some data quality, so we're doing huge amounts of validation in this area because there are some patients that are appearing on the waiting list for sleep studies that actually are already undergoing their sleep study. So we need to make sure that the data we're looking at is correct.
Apologies, I won't take this every time. What is a sleep study?
A sleep study is, for example, if someone does report to their GP or to their respiratory consultant that they are having very disturbed sleep. It's for things like sleep apnea during the night, and sometimes people have to have breathing apparatus or that or support. So it is a very important, it's part of the lung function service, it is a very important service, but all across London everyone's struggling with it, so that's our biggest concern at the moment. In terms of cancer, we're still very heavily involved with the targeted lung health checks, and they're going well. We have been doing well with our cancer clearance and particularly reducing the number of patients that breach the performance target. However, last week we received 32 new patient referrals for lung cancer, which is unheard of. Done a bit of analysis into it. They are coming from the normal referral service, so it isn't that a service somewhere has fallen over and suddenly they're sending them to us. It may be a blip, and it could be the blip of, September, going back to school, sorting out the parents' health problems, but we're not sure. So I think that's something we need to monitor and report back if we see an ongoing trend. That is going to cause a problem with cancer waiting lists, and I suspect that other providers might see it, or because quite often we get the patient late in their pathway for the surgery part, but the diagnostics are quite often done in secondary care. So I think that's something for us to just watch. Good news, can I have a good news story? I came to you last time saying we'd massive problems in critical care nurse recruitment. We had 26 whole-time equivalent vacancies, and this was limiting us running our 39, 40 level 3 beds that we've got. Great news, we held a huge recruitment drive, an open day, advertised it practically everywhere, and we actually managed to make 29 whole-time equivalent appointments. So it does go to show when you do very specialist and targeted recruitment that it does pay off. We're seeing the benefit of it now, but a lot of those nurses are still in their induction phase and their supernumerary period because it's such a specialised area. But the last person has now joined us, so that's a really good news story. Now we need to focus on the retention and support of those staff going forward to this day.
Brilliant, thank you very much. I was going to ask about that, then I read it and I thought, wow, that's really good. So that's congratulations on that, definitely. Just a quick observation, I think it's quite disturbing, obviously, that you're getting a big sort of blip as well as other blips we've heard about elsewhere. So yes, we want to find out more about that. The question I have is about ULEZ, actually, because obviously Harefield Hospital is right on the edge of ULEZ. Yeah. And because of its location, it gets lots of people from around the country.
Yes.
And also lots of staff who live not necessarily in London but drive to the hospital to work. I mean, in terms of ULEZ issues or ULEZ complaints, has there been a lot? Is it a significant issue, or is it actually something that's not been too troublesome for people or your staff?
So I have been very involved in these discussions, especially last August when we were rolling into this period. There was less noise than we expected from patients and staff, but there were some comments, and there was a lot of staff that did have to go and upgrade their vehicles as a result of it. The position of Harefield is quite unusual in the fact that normally it has two entrances. It has one on Field End Road, which is the main entrance, which is inside the ULEZ area, and it has a back gate entrance, which is outside the ULEZ area. So to begin with, the advice that we gave I'm not sure I should be saying this on YouTube,
That's fine, you're complying.
We gave our patients and our staff the advice that please do leave via the back gate if you want to avoid the ULEZ cameras. However, it's very hard to then progress your journey anywhere beyond that because you're kind of surrounded. Unfortunately, due to antisocial behaviour and a major theft of cabling of a generator, we've had to shut our back gate because it's not in good view, despite having CCTV, and we had a considerable theft of a generator, and that back gate is now shut. Again, I expected to hear more noise at that stage about it, but there actually hasn't been a lot. But the risk of potentially further cabling being stolen and generators not being available to kick in the event of a power cut, that risk was too high. So at the moment, the back gate is shut, but haven't heard a huge kickback as a result.
Okay, thank you for that. Councillor Martin.
Hello.
Hello.
First of all, I want to commend the hospital. It's a remarkable place to work, and meeting the patients day to day, it's very rare to find an unhappy patient with the level of care that we see. So from a slightly biased perspective, it's nice to see. As you know, EPIC rolled out last October, and it presented some challenges for the staff and the patients alike. Fast forward a year into EPIC, do you have any information to the success the staff are feeling from the benefits of EPIC? Are you happy with the rollout of EPIC? And have you had any staff feedback that you can share with us about the feedback of the introduction of that system? And how is that system performing? Because there's been a few times where the system goes down and there doesn't appear to be a backup electronically from the perspective I see. And just wondered how it's all going.
Okay, I'll try. You might have to... Oh, I'm not really speaking into my microphone. I do apologise. You might need to prompt me for the different parts of that question. So it's almost a year. It was the 4th of October last year that it rolled out, so we've just had the 1-year anniversary. If I was to walk around the hospital and talk to staff, which I do regularly, the response will be very different depending on the groups of staff. So if you were to go to the wards and speak to the nursing staff, they would say this has actually transformed nursing care on the wards. They like it because they can review all their patients on certain dashboards and see immediately where there's problems or where there's things that haven't been done. If you would speak to our consultants who are doing outpatient clinics, they will give you a less positive view because in their mind it's added time to their consultation to record everything. Some of that is being tackled by group and one-on-one sort of targeted interventions. So, for example, there are an awful lot of shortcuts in EPIC that nobody knew when it was rolled out, and actually we're now doing groups. For example, we've just targeted our cardiology consultants, and we've gone, here are the targets that will speed up. There are certain phrases, there is speech recognition as part of it, and they are happier with it. So I think there's still a long way to go. In terms of the success of it, I mentioned already when I talked about the sleep studies and that waiting list, there are some data quality issues continuing, but that I think is to be expected at this stage of a new EPR rollout, and I'm kind of looking at Jason, who's recently also had an EPR rollout. That will get less and less as we go on. Has it been a success? It has an amazing reporting facility that allows us to see around the hospital how full we are for our beds, what our patient flow is like, where intervention is needed, planning our future discharges. And we actually used it for an event in March called the MAID event, a multi-agency discharge event. And I'm not a regular user of MAID, but I sat in the room that day and I was like, wow, look at the information they can get at their fingertips. And we're actually having a further MAID event in the beginning of November, so I'm no doubt we'll see further use of EPIC since then. So I think it's a journey. I think we've got some way to go, but I think the exciting bit is what we're going to be able to get out the other end.
And just to follow up on the reliability, there's been a few, because it could be to do with the poor Wi-Fi around. It really does move around the hospital.
Yeah.
And sometimes there's been some updates which takes down the system.
Yes.
And are there any plans to sort of
Yeah.
smooth that over?
So like with everything, it did roll out with a business continuity plan as to what to do if we had downtime, that staff would be able to convert to manual if necessary, for example, recording of observations, or that they're stored on the machines, and when Epic comes back up, it transfers across. The first time that we had unplanned downtime, it was tough, because everyone was doing a process that hadn't really been practiced. We are getting much better at it, and actually there are now planned routine downtimes for maintenance and updates, and that is working better as well. There is also a certain number of key computers around the hospital that even if main Epic goes down, you still get it on those machines. They kind of call them the mothership machines. So those machines are being used more and more during each downtime. So it's getting better, but I agree at the beginning the first downtime was, a bit hairy. Yeah.
Epic, as Councillor Martin said. Good jokes. I thought I'd be credit for that. Thank you very much. Councillor Nelson.
Just in regards to the capital investment and the amount of patients now you having to deal with the rise in the cancer that you've seen in the department, how is the fabric of the building upkeeping with that?
It is challenging. Our worst estate is in, I think I mentioned at the end of the paper, our acute coronary care unit, which consists of 2 wards, Oak and Acorn Ward, where both level 1 ward care and HDU care is delivered. They are a porta cabin that have a number of years left in their lifespan. We are unlikely to get funding for a new hospital because our estate is not as bad as others. We also are in an interesting situation in the fact that we fall under South East London ICB because of being part of Guy's and St Thomas's, but we sit in North West London. So actually getting an ICB to commit to capital to do some of that's going to be challenging. What we are doing at the moment, though, is we are looking at sweating our assets that we have in terms of space. So, for example, where we have outpatient and diagnostic pressures, we're using our site 6 days a week now instead of 5, so we're able to build in more capacity. But in terms of will Harefield be rebuilt at any time in the future, we are working on a strategy at the moment, a clinical strategy for Harefield, for starting really 2030, saying what's this hospital going to look like, what services will it be delivering in 10, 15, 20 years, and therefore what does the estate need to look like. And it may be that we partner with medtech, academic institutions and building up research collaborative to develop a partnership that will allow funding of the building of a new hospital, but it's early days.
Thank you. Councillor Cawthorne.
Thank you. 2 questions from me, brief, I hope. One relates to recruitment. Very well done on that. That's really encouraging news. As one that comes from an HR background, of course, I know that retention is as big a challenge. And I wonder how you, without giving your secrets away to partner organisations, what you could say about how you're approaching that.
I think the main success of it was actually bringing and making the recruitment responsibility of crit care instead of HR department. That doesn't mean that HR weren't doing a good job, but I think when someone's inquiring about a job, there's nothing like speaking to the matron of that area and, you know, having organised visits and things like that. I think also if you know that you're going to potentially not have staff, you do a very good job of selling what it's like to work in this hospital, and after interviews keeping delegates hot and informed rather than long times of silence without offer letters or, you know, information we're waiting for your CRB check or whatever. So I think that is one. I think having the whole site targeted on a recruitment day is really key. So we had occupational health there, we had our staff psychology team there to show what services we have for staff. So I think it was a combination of making it more responsibility of the department and giving them ownership of it, and having the rest of the hospital involved in the recruitment day.
Thank you for that. And just moving on to my second question, it's pleasing to see that you gradually recovered from the cyber attack. I guess it's a fact of life in the modern world, and cyber security is a big issue. I risk exposing my IT lack of nous, because I'm not an IT person at all, but I'm going to ask the question anyway. I wonder to what extent the Trust can learn from the experience that you've had, to what extent there's perhaps opportunities for collaboration with the wider NHS in terms of sharing best practice and experience to minimise that risk in the future. Thank you.
I admit I'm no IT expert either, so forgive my slightly lack of technical explanation. From the time that it was discovered it was a cyber attack, which was probably 6 to 8 hours after things started to go wrong, we were working with the National Cyber Security Unit and also the Department of Health and their cyber, I think it was NHSE's cyber security rather than Department of Health. They are still pulling, because it's only just recovered really, there is going to be a full review and learning shared of that as well. But as you said, it is becoming more common, particularly British Library was targeted just before us, so there is learning to be made here and to try and prevent it happening, but very disabling during that period.
Good stuff. Okay, thank you. So we're now going to move on to Clinton Beale and Chris Reed from the London Ambulance Service, and there's two of you, so if you both want to speak, I will extend the 5 minutes very generously, so but go for it.
Thanks very much. So I sort of appreciate the first 5 lines of the update. It is quite management speak, so I'm going to sort of explain it in a different way, really. And we touched on this before. We're getting an ever-increasing population, an ageing population with comorbidities, so we are constantly looking at efficiencies and how we can actually improve the services in what is probably our most financially constrained times in the NHS. It's certainly the most I've seen in the years that I've been in. So what we're doing is a huge amount of work, and those 5 lines don't really give it justice to the actual work that we've put in looking at this. And the main headline of it is we're looking to take some of the pressure off our centralised services and bring it in locally into Hillingdon. And the reason for this is that we probably can make slightly more information-based, intelligent-based decisions on how that we can resource our ambulances, knowing our staff inside out, making sure we have accountability for our equipment and our vehicles as well. And so this is quite an exciting piece of work for us, but quite a huge amount of work for the team that are imparting on it. And I'm looking forward to realistically being able to give you results at the next one. We've only gone live on a couple of the work streams in the last week, but early results are showing some fantastic improvements in out of service. And this is a big challenge that we have actually with our ambulances. They break down. And they are out there 24/7. Kit goes missing, kits gets contaminated, staff go sick, and all of these things have an impact on how we can respond to the public. And so this is a huge bit of work that we're doing. But I look forward to the next meeting to be able to actually highlight, the success or not of those trials. One big thing for me, and actually I was really pleased that Councillor Farley, you talked about this earlier about the welfare of staff, and this is something we take huge importance in. And actually one of the things that we can't ignore is some of the recent headlines in terms of sexual safety in emergency services. And a huge amount of work has been done, a huge amount of focus, and this is based on some of our staff survey results about sexual safety. This is within colleagues and also just the patients towards or the service users against our paramedics. Sadly, we get assaulted. Sadly, there are these incidents. And so every single member of my staff over at Hillingdon has had a training session on this, and that's empowering them to be able to report concerns, making sure that they've got the referral pathways out there to support them, make them feel comfortable to challenge if there is inappropriate conduct, and to absolutely make sure that the Trust position is clear on this, and that it will be robustly managed if we ever see any wrongdoing. There was a recent Sky News report that was difficult to hear, and we absolutely tackle this head on. And this is really something that we're important. So I'm looking forward to seeing hopefully improvements in the staff survey. It's just been released, so we've got a sort of period of requesting people to complete it, and the results will be out early next year, certainly probably in time for our next update. So really keen to make sure that we see some improvements there. The a little bit of an advert, really. I mean, it's very difficult for us to be able to explain what our work is, but we've had cameras following us around, and this is probably one of the...
Why didn't they come here to us today?
To in order... No, I'm not going to be rude.
We could have been...
What I'm going to ask is actually people to watch the next series of Ambulance on the BBC. It's out on October the 16th, and I think this is actually a good indication of what happens. A good indication. There's lots of fly-on-the-wall documentaries, I appreciate that, but this is a good indication of what goes on and the challenges we face, and actually it probably highlights it much better than me and Clinton can do here, and we would welcome any questions off the back of that. I've avoided the cameras, thankfully. You might get a glimpse of Clinton every now and then, but
open fracture, so I was filmed.
Yeah, so you might see some recommends. But with all seriousness, I do think it is a representation, actually quite clear of some of the things that our clinicians have to face in a day on. We've talked about the increasing numbers, and sadly we have seen a slight drop in our Cat 1 time. We're monitoring it consistently. Unfortunately, we've gone up a little bit in the last period of about 7 seconds to our Cat 1 response. The calls have gone up 13% with no real improvement in our staffing estates or front line. So although we're doing our best, we will continue to monitor it and see where we can do. And just finally, conscious of the 5 minutes, in terms of what we were talking about, our demand that we put on the Hillingdon Hospital, there's been some great work, and we've got some sessions coming up with the Urgent Care Department at hospital. They're coming into our training days, so we can really discuss what we can bring to them rather than what we take to the ED, and really welcome that sort of collaboration with education for it. I'll leave it at that. Thank you.
Thank you very much. My first question is really about actually staff morale, because obviously when work goes up, ultimately you're not a business who can say, oh sorry, we're full or we've sold out of our product. You are an emergency service that people rely very heavily on in times of stress and obviously big incidents. But I'm very conscious that the people working for you, they're going to rise their sort of tired stress levels. So thank you for the update about the sort of the training that you talked about in a very important area, but just in general, are you monitoring to make sure there isn't burnout and you get a problem associated with long, lot bigger sickness leave, which then feeds in and it creates a cycle? I mean, is that something that you're on top of and concerned about and trying to manage?
It's a continual concern. So I think there was some huge learnings taking place from the COVID pandemic. And during that, the Trust has put on what we call the Wellbeing Hub. And this has grown and grown and grown year and year with different referral pathways for staff that are struggling. And forever seeing new ways that this has been improved in terms of financial support, in terms of different conditions that people might be struggling with, certainly in the workforce, ranging from neurodiversity to the menopause to all sorts of different kind of cases where people can seek help. We have fantastic links with councillors, physio networks, and so it's something that is taken incredibly seriously, but is constantly reviewed. Our high proportion of our sickness rates is stress related, and so it is a concern, but it is something that's monitored, and I really would like to applaud the work of the Wellbeing Hub centrally that have put on, because this is a great work that staff now rely on.
Thank you. My second question is around, obviously, I think it's about a year ago, though time's really hazy, might even be longer, but the police announced, obviously, that they were going to limit the amount of time, in terms of coming to call-outs for those who are suffering mental health episodes, but there wasn't a obvious criminal safety problem. And there was a fear at the time this would cause a lot of extra work, especially for the ambulance service, who are the frontline people, who generally, not always, but come first when those things are happening. So as we've had at least a year, I think, of this sort of London Metropolitan Police policy to free up police time to do what they perceive to be more policing, and we can all understand that. I mean, have you noticed the impact on the ambulance services and taking extra time to do your work because of it?
So in terms of time, no. Whenever we've asked for the police, and there is a sort of risk, that they're there, in different times of response depending on the time of the day. personally, I do understand the whole idea. What we found on a personal level when I go out to calls, and I'm still regularly doing shifts, sometimes their presence actually can exacerbate the problem through no fault of the officers at all, just having that uniform there, and actually it makes it difficult to create that rapport. On the whole, although we see slight individual incidences that we deal with, that we can give feedback on the whole, it hasn't become an issue that I'm concerned about. I meet regularly with Chief Superintendent Wilson of the Metropolitan Police, and we've got a good working relationship so that we can actually talk about any concerns that we have in regards to that. But actually, given the year, it's probably about a year now, that it isn't one of my main things that keep me up at night.
And that's an important indicator. Councillor Bells.
Thank you, Chair. I'm just concerned. I see your call times, etc. On the roads in the borough, they seem to love digging them up, especially during the summer months.
Yes.
And do the facility, the organisations liaise with the ambulance people? Because I often drive down Long Lane and it's hell for drivers. What would it be like for you guys?
It's something that we've always had to deal with. It's always had to do it, and I've got to say that they do liaise with us. We've recently had an inquiry about that as well. The difficult we've got is that we're almost bombarded with too much information, if I'm being perfectly honest, because if you think of the number of roadworks that are across the borough, it's very difficult to really assess the impact on an ambulance station of two potential traffic lights. So although we're engaged with it, these come into my inbox. It's really difficult to find the capacity to really analyse the impact of it. Our staff are trained to drive safely, progressively, and that includes throughout roadworks. So yeah, they do cause a delay, I'm not going to lie, but they are obviously essential roadworks that are needed to make sure that our roads are safe to drive on in the first place. So it's a difficult balance. I've got good contacts with probably people in this building to say, and I've raised a concern yesterday about one particular set of traffic lights that is causing a backlog up into Brunel University and the roundabout there, quite near to our ambulance station, and I got a very quick reply explaining what they're doing and how they're fixing it. So I was reassured that if I've got a concern, that they fix it as quickly as we can. But the difficulty is there's hundreds of them across London, and we don't just go to our borough. We are the nearest ambulance. So some of my crews found themselves in Cricklewood at the end of the night the other day, and it is a challenge that we face, unfortunately. But I'm confident we've got the pathways and the connections to highlight anything that's of a real concern, and the reporting structure as well. So if a crew find themselves particularly delayed and think it's dangerous, we have our internal reporting system that can highlight it and make sure it is fed back, not just like an email or anything like that.
Thank you. That's interesting to hear.
Thank you.
Councillor Nelson.
Just one question to you. How did the staff receive the award, and what was the uptake on it? Because that obviously boosts morale with staff.
It will do so more when we receive it. But I do believe it's coming in the next pay packet. We're talking about the 5.5%, aren't we? The pay, is that what we're just to be sure? Yeah. Yeah, that's a big help. It's there's different views on it. There really is different views, because people think that actually it's is that proportionate with other people in public services and things like that. It has helped. Let's keep it at that. I think it's helped and it's welcomed.
Thank you.
We'll always want more. Sorry.
Excellent. Okay, thank you for that. Councillor Farley.
Thank you, Chair. Thank you for mentioning about the staff, because it is something that does concern me. That we've had a lot of difficulties in the NHS and associated partners' delivery. You mentioned in your speech that you had a lot of thefts, obviously assaults and things, thefts of equipment and things. And obviously, sort of leading on from what you mentioned about the police as well, in attendance at certain scenes. I'm just obviously police now wear body-worn cameras.
Yeah.
Is that something that is being rolled out for ambulance service? Do you wear them?
Yes. Just quickly, I think on the theft, I think you mentioned that sometimes pieces go missing, don't you, rather than thefts?
Oh,
just for clarity on
yeah,
that.
for clarity.
I mean, but obviously the main question is still the main question.
No, absolutely. So yeah, there are thefts, but it's not the issue. The issue is like broken equipment and things like that in that respect. Okay. But in terms of the assaults, we have body-worn cameras that staff wear.
Okay, that's good to know.
Yeah.
I was just curious if it was a theft or something was going on.
No.
Whether or not that you had CCTV on the vehicle or.
Yeah, no, we have CCTV on all our vehicles. Now it's a really difficult governance piece because obviously we've got to make sure, and there's strict policies on that this is viewed in a very controlled way because people's medical histories are discussed, intimate. Surgical, we're cannulating, we're intubating, we're doing all sorts in that truck, so we've got to make sure we're not breaching confidentiality. So there's a strict way, but actually we have CCTV surrounding the ambulance and within the ambulance, and with body-worn cameras, this has really helped our conviction rates for this. So it's definitely a positive move, and it's probably in the last 2 years we've rolled it out. The difficulty sometimes is getting staff to wear them, if I'm honest, because we've got enough kit on us as it is, and it's another thing that hangs off your shoulder with the radio and trying to actually be doing it. But actually more and more staff are using it these days, and it is certainly helping us push a conviction when someone has been assaulted. So, yeah.
Thank you. That's good to hear. So thank you for that. I also you mentioned your shift. How long is a shift? I'm curious, because then sort of how much time is then spent waiting at A&E?
So our shifts, we have a rotating shift pattern that are 12 hours. 12-hour shifts, no more than 4 shifts on the trot, and no more than 3 nights in a row. So we had a recent, this time last year, about August time, when we went to Team Space Work and we had a rota review, where staff side representatives, so the unions, members of the staff in all aspects are brought together in a working group to work out the best rota based on our demand profile. So we can't just work whatever we want. We've got to make sure that we're there when the demand is high. It's again, we'll never get a rota that pleases everyone. It's really difficult, and I've had we have challenges, but we try and make sure. I vividly remember 85% of the rotas that we offered, one was voted on. So we know we got it pretty right for the feeling, but we do listen. Apologies, I think there was a second part of that question.
Well, it was sort of going from that. So I am aware, instead of saying Hillingdon or any other hospital, but generally hospitals, how much time you're spending being able to go out onto calls compared to where you might be in a queue waiting to release your patient into the care of the hospital.
So I think it was about a year ago again, the W45, well, it was a trial at the time, now it's now business as usual, where actually if we're waiting for longer than 45 minutes at the hospital, we leave. And it's not going unnoticed how much of a challenge we've put on Hillingdon Hospital but it's not just Hillingdon, it's the trust-wide, and I dare say it nationally, is it a national, it's a national thing. And it's the right thing to do. It is the right thing to do, but it doesn't, because, we can manage risk within the hospital, but actually when we've got people, out there who are not having us respond to them, it's a higher risk. But it doesn't go without saying what a challenge we put on the local hospitals when we do that. So at 45 minutes we walk out. If it's taken that long, quite often it doesn't. Quite often we hand over within 10-15 minutes and then we can go about our day. But that's very difficult when there isn't the beds to transfer that patient onto. And we've worked out ways around that, haven't we, in terms of spare trolley beds to do so. But also there's quite often, it's not always that easy when our clinicians have built a relationship with that patient, they realise their vulnerabilities and also with the pressures at the hospital going on. So we don't always do it, I won't lie, but we monitor that. We get a daily report on how many times we've breached that 45 minutes. Thank you. But we do, it has massively, and I haven't got the figures, but we did last time, massively reduced our time lost at hospital metric. That thing.
Thank you. Councillor Martin.
Hi, in your notes you mentioned about your organisation becoming increasingly inclusive, and as we know over the last few years, many of the emergency services in London in particular have been criticised for how inclusive they've been and some of the issues. around how that feels. What work is your organisation doing to make sure those from LGBTQIA+ and minority backgrounds are feeling how they're included, and do you have any statistics to share of how that's improved over the last few years?
Yeah, that's a really good question. It is a huge focus. We are keen to represent the public we serve, and the only way we can truly do that is having those right proportions. So it is massively important. There is trust-wide work going on with that, and monitoring. We have focus groups, LGBTQ plus focus groups that are making sure that we're championing developmental opportunities for staff in all areas of EDI elements, and making sure that we're doing everything we can to support them. It will be one that I'd like to present back, actually, and I'll make a note of that to get you some figures for the next meeting that we do. I haven't got them to hand now, but I know it's a huge focus. Operationally, it's not something that perhaps I would get involved in personally, but I know that we have quite huge groups within the trust that focus heavily on this to make sure that that's right. It is incredibly important because it's the only way that we can represent and actually serve our public in the way that we would like to.
Councillor Corfield.
Just one on this one, and Chris and Clinton, it relates to calls that the service must receive from time to time. When the paramedics turn up, assess the patient, some kind of judgment needs to be made about what's the most appropriate next step. Not necessarily a transfer to hospital, but I guess there are opportunities perhaps for you to consider alternative pathways. I mean, do you get many like that, where perhaps in your professional judgment, perhaps transfer to acute unit is not necessarily the right thing? 100%. And might that have a link back to what we were talking about earlier, understanding of other services, etc.?
This is a huge, absolutely, a huge part of our education, our training. We anticipate, and roughly, I think, on the last sort of set of figures in the last 3 months, only about 50%, 52.1% of patients were taken to the ED. So actually, it's a huge part of what we do. We have various ways to make sure that's clinically safe. So we have, for our younger clinicians that are just through their sort of newly qualified period, to make sure that they're making those right decisions, because there is a risk, and there is only usually 1 or 2 of them to make that decision. It's not like you can go and ask a consultant or anything. We're in an ambulance on our own. So we have pathways called Pathfinder, which is on their iPads, and it's a useful tool to make sure that any red flag conditions or any red flag symptoms are not missed. They also have a clinical hub that they can ring to discuss it with a more senior colleague. But this is absolutely part of the work that we do, and I was running out of time, but I rushed it at the end. But actually what is important is that we collaborate with the urgent care centre at the Hillingdon Hospital to make sure that we're bringing patients properly into their urgent care department, so that which is fundamentally an alternative care pathway. It's not the ED, it is an alternative care pathway. But on top of that, we also get people in from hospices to talk about end-of-life care, because that really is inappropriate if it's against their wishes. It's almost, it's illegal if we're taking people in against their wishes when they're in a dying phase and actually acutely unwell. But to try and get that history when you've just got there, it can be incredibly challenging for our staff. So, huge focus, and we're ever striving to get it right. I always have a struggle with that figure that I report on, of 52.1% figure, because it depends on the condition of the patient. Do you see what I mean? It's not something that I want to see at 10%, because I think we're getting it wrong, and I don't want to see it at 9%. So I don't know what the golden figure is on that, but what I can reassure you is that regular audits of this happen. And recently we had part of our clinical directorate basically had an audit of the front door at Hillingdon Hospital. As crews were going in, they would interview them after they handed over to find out the appropriateness of it, and we were able to give feedback to the staff that if there has been something that they perhaps could have thought of, or a different alternative care pathway. The difficulty is like 3 a.m. That's when you find that quite often they're not available, but we work around it.
Can I just briefly say thank you for that response? I'm very glad my question gave you the opportunity to share that with us, because it is reassuring to know that's happening, I think, so thank you.
The system's working, maybe? I don't know, we'll see. More questions and time. Anyway, excellent. Thank you so much. That was really interesting. Now we're going to move on to Keith Spencer. And what I propose, after Keith, you've spoken, Ritu, if you want to say anything, you can at that point, and then we'll have questions from both of you. I think that makes most sense. So, Keith, you go first.
Thank you, Chair. I'm glad that slide is still up. Oh, it's gone now. Apart from the dapper picture of Jason Sees looking at me, which I've seen for most of today, there is an important point behind it. You won't have a new hospital in Hillingdon, unless we do something different in our out-of-hospital space. Everything that we write into the business cases and things is contingent on us doing something differently in primary community care and health services and adult social care. I wanted to focus tonight on integrated neighbourhood teams. We have this year, there have been 8% more GP appointments than the previous year. There's no other service around this table probably could cope with that increase in volume. I'm talking about millions of appointments that has gone through. What we're trying to do in the context of HHCP here is create integrated neighbourhood, is create a different infrastructure for how health and social care operates in Hillingdon. And I've forwarded you the interesting North West London ICB document on neighbourhood which we've contributed to, only to show that the work we've started here is ahead of the curve in terms of what is happening. But I want to focus on a couple of things. So you've heard from Claire this evening. You will hear from Ritu in a moment. And the feedback that they've given you is part of the work. If they are HHCP, that's what they do. I just sit behind a desk and answer difficult questions from various committees. But where we are at the minute, we have created 3 integrated teams. They're anchored by primary care networks, by general practice. We've created a leadership team for that, which is multi-agency, which is a single leadership team. There's no other organisation, no other place in North West London where staff are managed from different organisations by a single leader who happens to be appointed by one of the partners. So a huge change in that. Claire's talked about the realignment of community nursing services. Community nursing services previously were aligned to the borough level. We've now realigned them to the neighbourhood level, or in the process of doing that, and Claire has got the scars from leading that piece of work. You'll see in some of the examples we've given there the work that's being done in terms of bringing pathways together. So first of all, back in July, for same-day urgent primary care, we hit the appointment target that is required to deliver the new hospital. We did that. And we've done that from interim hubs, and I'm going to come on to a state in a minute, because I think that is a key disabler for what we're trying to do. And we flagged this today for the benefit of the ICB. There's a little paragraph there on integrated therapies. We've started to create an integrated therapy team. That work is led by the lead therapist of the hospital, Alex Porter, who has quietly in the background created a single pathway. Take the therapists, so the physiotherapists from the hospital, from CNWL and from primary care, and created a single virtual team. And you may think, well, what are you waxing so lyrical about? It's the final line in that. What we've been able to do is a pathway developed to enable community physiotherapists to refer directly to orthopaedics, and for physios to refer to X-ray. Now you're probably sitting thinking, well, what's such a big issue about that? Previously, they couldn't do that. They had to go through and via their GP to do that. So we've given a direct route, and that's just been done just like that, and it's actually transformed GPs were clerical in the north about that change in terms of what we do. What I wanted just to say is what we want to do is to bring these teams together into a co-located space. You have no idea how difficult that is. I'm sure Jason knows how difficult it is. You think we'd ask people to grow up themselves with a rusty cheese wire to enable that to be done. And the barriers that are put in the way. There's not a penny spent on capital infrastructure for primary care. Yeah, we've got primary care operated from semi-detached houses in Hillingdon. Yeah, and you look at the pictures of the state-of-the-art hospital. Jason's assumptions rely on primary care community services being able to deal with a different type of patients. So what we are doing, and this is my way, Nick, of flagging this for future discussions, is we are working with the council and with, to a greater or lesser degree, with the ICB, about trying to get clarity about investment in estate, in out-of-hospital estate. So I'd love to be able to deliver community physiotherapy in Uxbridge. We haven't got a place we can put the plinth to do it. We haven't got a practice big enough to put the plinth on it. Never mind state-of-the-art X-ray equipment. We can't even put a plinth to put people on that in there. So that's where we are. And shows you the distance to travel between that is important. So that piece of work, that estate option appraisal, is critical to getting estate which is fit for purpose for the people of Hillingdon. And that's we're putting. I spent part of my life doing three things: estate, discharge, and better care fund at the moment. And that's what I spend my life doing. So really important that gets unlocked. And I think also that we recognise the pressure and the work that primary care are doing at the moment, and they're working with us to make this in reality. So I just wanted to get the gap, Nick, if I can.
That was really interesting, and it's a good way to sort of end your sort of 5-minute time. So no, thank you. And actually, I mean, it's not really a question, but I think a visit for the committee to one of these sort of super integrated hubs would be really useful once you think that's appropriate, because you've talked about this for a while, building this, and that is really, we are interested in it. But I think nothing beats going down and seeing it and seeing how it works and speaking to people in there. So if at some point, speak to Nikki about possibly having a visit, that would be for the committee. I think that would be really useful. Great. Sophie.
Welcome that. I'd also like to take you to some of the GP practices where it's not so good to visit.
Of course. Yeah. No, I think that's good. Well, of course, and that would be really useful for us as well. So maybe you and Nikki can chat about. I think us having a visit out and seeing some of these things in reality would be very useful. Ritik.
And just to add to that, I mean, some of the things that Councillor had picked up is about this people knowing where the services are. So, for example, mental health. So what these neighbourhoods, the 3 neighbourhoods, we've got neighbourhood directors who are trying to get everything in place, and they're assisting primary care and colleagues like Claire's team to start this piece of work of developing these integrated care teams. So it's not only going to be primary care, it will be community nurses, it will be community matrons. It also will involve mental health, because it's a wraparound service around the patient rather than them ping-ponging from different services. And the advantage there is that the patient gets seamless care, and the GP time is also not wasted in just doing referrals, because that's what we're doing. Okay, you're seen by this service, can you refer to that service? And that's what Keith just highlighted with the physio as well. And also allowing patients to be able to self-book as well. So what Alex has managed to do is great, and the next step is that people would self-refer if they felt they needed to on the next step, and that would avoid DNAs as well. So with the neighbourhood teams, we are looking at north, south, east and southwest, and different areas have different priorities. A lot of them are very similar, like mental health, it's hypertension, cardiovascular disease, diabetes is obviously common, but there are things like in the north where we have more of frailty and older people with a lot of comorbidities. We are looking at frailty as well and respiratory problems, because Harefield is one of the areas where we do see a lot of it. So we're focusing on 3 or 4 key priorities, and that's what the neighbourhood directors are working on. They've just started. I mean, they're literally, some of them have been 2 months in post, some of them literally 4 weeks, but they've been great, and they've come with a lot of experience. So hopefully by the next time that we meet up, we'll have something more concrete to deliver. And that's the intention, that we start working together. We're not working on a 5-day week service as well, and that's what Keith has pointed out. Develop these 7-day working in conjunction with community care, where there's a lot of interaction between primary care and community care as well. Plus, we're also working with a lot of the hospital staff to bring certain specialities out into the community, because if you look at the we met up with some of the councillors there, and what they said was, could we not have our clinics in the community rather than us spending a day out in the hospital? So that's what we're working on with the respiratory team, with the care of the elderly, and also with mental health for older adults as well. So we're in the phase of just getting these pathways organized, and with mental health, a lot of transformation work has gone on where we are developing maps along with the council, so that patients can just put in their postcode and find out what the services are, what they can access, and what are they providing. So that will ease the burden on secondary sort of specialist mental health services as well. So what we focused on is, in one area is children and young people, the other one will be dealing with adults, and one area will be dealing with the older adults, so that we get all the pathways smoothened out and then it's spread across all of Hillingdon.
Thank you, that's really useful. It's I mean, it's how health is organised is as complicated as the human body in terms of things leading on to other things and systems in place, isn't it? Yeah, no, definitely. I mean, I've been doing this now for 4 and a bit years, and I'm still getting to grips with it all. But it is important because everything does link up. Right, I'll stop wittering because that defeats the whole time thing I'm talking about. I have one question, and it's about the ambition for having a good 7-day service, equal 7 days. Because for those who forget or weren't on the committee when we talked about this in the past, essentially, obviously, health matters are 7-day matters because health matters happen. I mean, some of them you can plan for, but a lot of them just happen. And people's lives, in terms of when they can access support as well, is not necessarily Monday to Friday, but obviously the traditional working week, a lot of contracts, a lot of services are provided 9 to 5, Monday to Friday. Now, Keith, a while back, you definitely talked about an ambition of moving more to that 7-day working week, and obviously Rita with GPs, and it's very important to have, access outside when people are working. So I just wanted to sort of get your views on how are we doing and working towards having a good coverage over 7 days a week for our health services.
I'm going to look to my colleague to the left who is so the focus at the minute is so what we know is our focus is on discharge over 7 days at the moment, because what we know is that on Saturdays and Sundays the number of discharge we get reduces dramatically. In fact, we have a surplus of discharges Monday to Friday over admissions. We have a deficit over weekends. In fact, all the gains we make in the week are lost over the weekends. So the work that Claire is doing with her counterpart Rachel Tunstall, who's the deputy coup at the hospital, is how we move to 7-day therapy service, what we call a pull model. So please don't get the wrong end of the stick. We're not pulling anybody out of the hospital physically, but how we get earlier discharge. And the work that Claire's leading with Rachel is about how we do that, particularly on therapy services, because it's therapy, OT, and physio, which often make the difference to an early discharge at hospital. So we're literally putting in, as we speak, proposals to try and move to 7 days in those areas, and Claire's trying to get, with Rachel, trying to get this one running as we speak. I don't know if there's anything you want to add to that, Claire. I know this is... Please do.
No, it's really notable from the figures that it definitely drops off. Patients waiting on a Friday for OT, PT, and then that delays till Monday, and then we're recovering, and we see Wednesday, Thursday, Friday, absolutely seeing an increase in the discharges. It's also around senior decision making 7 days a week, and we're really focusing on what that actually means and what that looks like, and actually what we can recommend back in the hospital as well as in the community and at the front end of the hospital around senior decision making. And we saw a difference during COVID when there were senior decision makers around, as well as the junior doctor strike. So that's another piece of work we're working on.
Councillor Nelson.
The system is working for certain aspects of things. The diagnostic side of things, as a user, as well as some family members, that's working. The patches system is not working as it really should be working, and my concerns are for those who are non-IT users. It's good for those who are IT users, but it's set up to weigh between 8 o'clock opening time to about 11 o'clock. and then between 4 o'clock to 6 o'clock, which is the opening time. But my concerns are for those who is unable to use that service and getting through to get an appointment is not very good. And those people who are unable to use that service, my opinion, but looking at certain aspects, I think this is where the flooding of A&E is taking place. So you said the GPs, your increase on GP face-to-face, more face-to-face GP services, but is it really working? Because it's not really, in my opinion, being seen like that. And those ones who are unable to access via the IT system is unable to get a booking appointment when they make a phone call.
So it's not a system that GPs like either, but it's something that is being promoted and moving more towards usage of digital technology. And a lot of practices, including mine, we've been quite resistant to just going totally digital. There are provisions that practices have put in for people who are not able to use the digital option, and they can ring, and the receptionists are trained to fill out the patches form. So that's one way of doing it. Plus, in practices, we do have alerts on certain patients that these patients are not able to use it. It could be age, it could be language barriers, it could be also some complexity as well, because they do need access. So they are prioritized. So there are various things that in general practice we try to accommodate every patient's needs, but it is challenging. The demand is so high that, yes, I agree with you, people who are digitally savvy can get access while the others are left. But then it's a question of trial and error, and everybody's trying their best to see what fits in. And there's a huge piece of work which we are doing, Northwest London is doing, about access. I mean, initially it was being rolled out, and we were told by October we all have to have this digital door, basically. But that has been put to a stop because of the patient feedback. So another survey is going out. So every practice works differently, and it's very difficult to standardize it because it's not suitable for everyone. And I completely agree with you.
You happy? Yeah. Thank you. Councillor Cawthorne.
Thank you. I think Councillor Nelson might have dealt with my first question, because it sounds rather as though what she was talking about was an email I had yesterday from my own practice about a new total triage booking system which is online, and yes, I would echo concerns about people who aren't e-enabled, if that's a word, and it sounds like that's something that we are looking at. So I won't dwell on that.
Was it said to you as a total triage booking service? Because I think most people wouldn't understand that.
Okay. Well,
we possibly would, because we sit here listening to
starting Thursday the 17th of October.
In terms of what it said it was, cause that's important in communication, isn't it?
Yeah.
What is a total triage booking service? It sounds like something I might order in a sort of ice cream shop. I don't know.
I'm happy to share the email.
So it is interesting. So just in terms of communication of what it is.
This is a Wood Lane practice. I don't mind people knowing that. That's fine.
I
did have another question, but apart from that, so if I can just carry on. First of all, about the 7-day discharge, Keith, you and I have been talking about this for many years. Bloody good luck with it. My personal view, as I think has been said, it's the availability of senior clinicians at the right time to make those professional judgments that's the key, in my view. Anyway, I wanted to ask about the estate point that you made, because again, that's another long-running thing, and certainly in my health and wellbeing board days, we used to talk quite a lot about estates and spending of Section 106 money and all the rest of it. From memory, one of the frustrations was that it was difficult to get money spent that was available. Whether the health partners thought there wasn't enough critical mass for it to something to go into one area or another. So I suppose my question is that where we still are? Are these the sort of discussions we're still having? Have we moved on from that? I'm just interested in how this is being taken forward compared with the way we looked at it in the past.
So the honest answer to that is that the cost of development and the cost of reprovision far dwarfs the Section 106 availability that we have. To give you an example, give a real number, the Section 106 funding we have available for the Uxbridge Hub is around 400k. To redevelop a site of that, we're talking many millions. of pounds. So that's the issue. The Section 106 is just insufficient to actually deliver what we need to deliver, which is why we have to look at other funding options, because the ICB has no capital either, and if it did, it probably wouldn't go to primary care, if I'm brutally honest. So we do have to look at other sources, which is why we're working with the council and with others, just in terms of how we might leverage this for people of Hillingdon.
Councillor, as a quick sort of add-on to this, last year we did as a committee request in a year's time, so like now basically, for the council to give us a report on their health spending related to Section 106 and what's left over. And I've just had a little chat with Nikki, and that request has been made, and we're hoping for the next meeting. So hopefully from our end, from the council end, we'll get some more information to this committee about what's being spent and potentially where there's possibility for funds on Section 106. So that would be very useful. Thank you. Councillor Chamdal.
Thank you, Chair. Dr. Prasad, this is an observation and experience as well. My surgery recently did a group session where they invited all the patients, similar to Councillor Cawthorne's, where they wanted to help the patients with patches. Now, they had a 3-hour session, but when the patients turned up, a lot of them were of an ageing population, and you could see the frustration. They were struggling to even get the patches system on their phones. Some of them didn't bring their tablets. So whilst I'm all for technology to a certain degree, why can't surgeries still employ decent, helpful receptionists who are people-focused and will allow you to speak to somebody? Because at the moment, if I call my surgery, it's very robotic, very cold. This might be something for Health Watch update as well, as a complaint, but they're not the receptions that we knew years ago, because they're conditioned to do, well, this is the pathway that you've got to take, and they're very rigid with the patients. So is that something that you have an option of, or is it just simply patches and that's the way we're going?
The receptionists are still there. We can't do without receptionists, because they are our front door and the front face of our surgeries. And I think a lot of surgeries do invest a lot because they represent you with the patients, because they are the first base. And having good receptionists is becoming a challenge because of the certain generation. People are retired because of all the new IT and they can't cope with it. And people who are coming in as reception, there's a huge turnover. They can't take the pressure. And it's the level of aggression that they face at front end is phenomenal at the moment. And I, in my career in 25 years, have never seen such a turnover of receptionists. They are crying at reception. That's the way. So I think it may be a protective thing, the patches or whatever they're promoting, but for reception staff it is extremely difficult, and nobody's got rid of them. I think it's just sheer pressure at the moment. So I get what you're saying, and we try our level best to support them, but it's very difficult at the primary care level.
Thank you. I mean, one observation I'll make is if you look at local job websites, there's lots of jobs for receptionists in GP, like loads, and so obviously you can just see it's a recruitment issue. Not that I'm looking for work, but anyway, maybe after tonight. Anyway, Councillor Burls first.
Thank you, Chair. Just got a question on these hubs, super hubs, because we set up hubs about a year ago, didn't we? GP hubs. How are they operating at the moment? And are they operating?
Yeah. So what we've done is we've set up 3 interim hubs in different parts of basically in different parts of the borough. But they are, as you say, they are GP hubs, and they don't have the space, and actually they're not located optimally to deal with that wider group of staff, and bluntly, they're not fit for purpose in terms of what we're trying to do. Because the space that we need is around 2,000 square metres, it needs to have nearly 130 staff attached to it, so they're fairly sizable and large buildings, which is why we're looking for alternative sites to move these to. So we set up interim hubs because obviously one of the assumptions around the new hospital is that we'd offer more same-day appointments, which we've done successfully, but they're not in the final location. And Ritu, before we started the meeting, was telling me how again we're looking for a further site in the south, in the south neighbourhood.
I think that's why for us a visit would be really useful, because we've heard about the hubs, haven't we? But we need to, and we've seen the papers, but we actually, to get a real feel for them, I think it would be great for us to come and visit.
I totally agree, Chair. I think it would be, and I've got a few ideas myself, which I'll keep to myself.
Excellent. Okay, Councillor Nelson, you only asked one question, so you have another question, so please go for it.
It's around the estate, and you're saying that's very difficult to acquire. Have you linked with the council to see if they have any estates available that can be used? Because that seems to be the big problem around the borough, is finding an estate. And the way how things are going, I'm just wondering, will you ever find an estate to deliver the service that's required?
So what I can say is that without the support of the London Borough of Hillingdon and Tony Zayman's office, we wouldn't have progressed as far as we have done to date, and the council has done everything to try and find a way through for this. So I mean, nothing but praise for the work that Hillingdon have done in terms of looking at how we can leverage funding, so on and so forth. So absolutely.
There's a Grade 2 listed building in the centre of Uxbridge, which I think has some space. But anyway, we'll take this. That's another chat for another point, another time. Okay, fantastic. Thank you very much. And so, finally, but certainly not least, Lisa Taylor from Hillingdon Health Watch. Please tell us about some of the work that you're interested in and some of the discoveries that you're finding at the moment.
Thank you, Chair. So I suppose, firstly, I just want to apologise for the lateness and get my report to you, just capacity issues, and you'll see just the sheer amount of work that we've been doing. And I suppose, actually, I'd like to also just start with providing some assurance to the committee that the concerns that have been raised this evening generally correspond to the concerns that we hear from the community on a daily basis, very much around staff attitudes in primary care, long wait times in A&E, issues with digital services, so that's the patches system, it's also the blood test booking system at the hospital, and access to mental health support in the community. So those do tend to be the things that we're hearing about the most. And so I'm really pleased to hear that mental health is going to be a priority in a review of services, and I'd very much welcome to be part of that moving forwards. So just to sort of give some headlines of some of the work that we've been doing, we've been working, we did a lot of work with CNWL actually in terms of reviewing the inpatient units at Riverside. So we looked at the ward environments, quality of care, communication with staff, provision of activities and meals, and involvement in care planning and preparation for discharge. And we looked across the two acute wards, Crane and Fraser at Riverside, Oak Tree, which is the acute ward for older people, Hawthorne, the Hawthorne unit as well, which provides rehabilitation for older people, and also Colham Green Road, which is also a rehabilitation unit for people that have been in acute care. We found that there were lots of areas of good practice and things that were working really well. I've summarised sort of what's working well, what we felt could improve, and obviously that differs depending on the wards. In the acute wards, there were lots of issues around security and privacy, food, activity, so physical activity, even though the gym is fantastic there, but it's about motivating people, I think, to go and use it. And then in some of the older people's units, the space was very welcoming. People generally praised the interactions that they had with staff. So lots of really good things. And where there's a need for improvement, CNWL they have developed an improvement plan on the wards.
So we're hoping to go back next year and just to sort of assess how well that's going. So we interviewed sort of over 40 patients, also carers and family members as well. So that was a really big piece of work and really time intensive, but very worthwhile. As I've mentioned before, we're reviewing children and young people's mental health and wellbeing services, and this is part of the 2-year NHS-funded population health management project. And the aim is to understand the needs of our local population of children and young people, particularly those that have poorer outcomes and poorer health, more health inequalities. So the objectives of that piece of work are to consolidate what we already know, identify children and young people who are at the highest risk of health inequalities and discrimination, and further understand what they need from services to be able to thrive. So outcomes to date, we've surveyed over 300 children and young people in the borough. We've established a voluntary sector forum of services that provide support for children and young people in the borough, and we have also facilitated workshops with looked after children, with young adults who identify as LGBTQ+. We've been doing lots of work with the Youth Justice Service to try and understand the barriers to accessing services for those young people that arrive in the service with unmet needs. We've been running workshops with young people with autism, and we're about to run some more workshops with young people in partnership with Hayes Muslim Centre as well. And we've also got lots more planned activity because we really want to hear more from parents, and also really keen to hear from schools around the challenges that they face in accessing support. Key themes from that, the things that negatively impact children and young people's mental health, relationships, social media, particularly around cyberbullying, exam stress, loneliness and isolation, and substance abuse, are sort of the most prevalent things. And barriers to seeking support from services include awareness of what's available, availability of services that meet their needs. So we've been told that there appears to be an inconsistency of support within schools. Some services they feel are inflexible. So environment, location, travel requirements, and also language barriers around the use of clinical formal language as well. There are some issues around trust and confidence.
You've come to the 5 minutes, but I do know that in your report you want to talk about experience of access to GP service.
Yes.
Well. So in terms of the children and youth work, there might be some questions on that. So if that's okay, if you can just sort of summarise that and then we can go into questions. Thank you.
Yes, so I suppose the other headline then is we're also running a survey on people's experiences of accessing GP services. That's ongoing at the moment. We've had about 200 responses to our survey, but we're also doing some planned engagement, targeted engagement out in the community as well, just to try and understand a wide variety of experiences. So yeah, that's about it from me at the moment. So happy to take your questions.
I mean, that is a lot. I do actually have a question on the children and young people's mental health work that you're doing, and it's not about the content on the Young Health Watch Hillingdon TikTok, which I'm sure is going to be fantastic. I'll have to follow that and see what's coming. But so the very, very extensive research is going on. It's really useful, and you're finding obviously some really interesting things. I mean, what will this feed into in terms of improving service? Because obviously we did a report a while back about improving services. Stuff is improving, and there's a transformation board which I kind of get invited to. But what is the hope from that research, and how is it going to help improve the services provided to our young people on mental health?
That's a very good question. Obviously, this has come about through a 2-year pilot. So, and it's a North West London pilot. So, the findings will be fed up to sort of North West London ICB, and I'm hoping that will influence how services are delivered. I think our findings will probably show that, and it's something that we have made recommendations around before in the last Seen and Heard report we did back in 2015, is around looking at the spending on mental health services and looking at how perhaps that could be utilised differently with more emphasis on early intervention, and that does seem to be what children and young people are telling us is needed. So earlier kind of conversations in schools around mental health and well-being, giving them the language that they need to use to express themselves, understanding actually what's normal and when they should be worried. Peer support seems to come up quite a lot. Mentoring comes up quite a lot in terms of recommendations, and really just having more flexible approaches to the way services are provided. I don't think that the piece of work we're doing will end there. Obviously, this is a culture change essentially, and I'm hoping that it will feed into the Thrive framework that everybody's working towards. One of our aims is to co-produce recommendations for improvement with children, young people, the voluntary sector, statutory services and schools, and we're hoping to put on an event probably in the early part of next year, and bringing everybody together to develop some solutions. But that's as much as Healthwatch can hope to achieve, I think, in that this piece of work will actually influence perhaps a change of mindset in the way that services are run.
Well, no, really important to evidence, the research and evidence of that, so that'll be really interesting. Thank you. Councillor Cawthorne.
Thank you, Lisa. It's good to hear your comment at the beginning about the sort of things we're raising resonating with people who are talking to Healthwatch. Did you mention a voluntary sector forum? Did I hear that correctly? And if so, can you just say us a bit more about that, please?
Yes. So one of the key deliverables when we put the proposal in to do this piece of work was to co-produce the project with the voluntary sector partners that are currently providing support for children and young people, because we felt that those kind of that sector of I'll say that again. Those services didn't necessarily have a place to come together and collaborate, and they really see the value of networking to be able to form those relationships, build bridges between their services to be able to support children and young people more effectively. The thinking around doing that at the time was that they felt that because Healthwatch were independent, that we'd be best placed to facilitate that, and it would be for the life of the project. And potentially one of the outcomes of this piece of work is a consortium of voluntary sector partners that focus on children and young people's mental health and well-being. Welcome.
Excellent. Well, thank you very much. Yeah, great. Thank you, and thank you to everybody for coming here. And even though we were super quick and didn't cover half the stuff we wanted to cover, we still spent almost 2.5 hours on all this stuff, but really, really useful. So yeah, we've got a couple more things to discuss, but you guys don't need to stay here unless you really want to. Thank you very much. Okay, so hopefully the last two agenda items we can go through pretty quickly. There is only two left. I'm losing my papers. Swinging papers, right. Here we go, fantastic. Does anybody, we're now on to item 6, does anyone have any comments on the Cabinet Forward Plan monthly monitoring? Are we okay with that? Fantastic. Okay, so we go on to item 7, which is our work programme. I've got some suggested changes to the work programme, so I'll talk you through them, but please do ask questions because there are some changes. It's a bit like doing a jigsaw or doing a Rubik's Cube, actually, to be honest. But anyway, so at this meeting, we originally were going to discuss the scoping report for our in-depth review into early intervention and prevention in adult social care. Due to the fact that we wanted some more data about what happens currently, we've shifted, which I think that's correct, isn't it, Mickey? Yeah. We're shifting that to November's meeting. So instead of having the first witness session at November's meeting, I propose that we move our single meeting review into pharmacies to that meeting. So we have that meeting about what are pharmacies doing in terms of doing more work, are they able to cope, what's the customer experience. I think we've all experienced go to your pharmacy and had different experiences. So I propose we move that there. also, for the 12th of November, we will discuss the Heathrow Villages bus evaluation report as well, which I've read today and I think we would like to talk about. And also we will hopefully receive the report about Section 106, which will be useful for us to discuss, but also think about future work in that area. So that's what I'm thinking for November. So we're expecting the CQC report probably in mid-November. So what I was proposing for our January meeting is that we invite the Cabinet Member for Adult Social Care and the Head of Adult Social Care to our meeting so we can question them about the CQC report and also in general about what's going on in those areas. So that makes sense to me. And so what that means is our free witness sessions will be on the 25th of February, 19th of March and in June, with the final report hopefully done for July. So so that's what I was proposing. It will all look clear when Nikki moves around the sheet.
Chair. Get a little bit more even over the next few meetings.
Yes, please, because obviously the last two can be moved around, and I mean, I think maybe we could have a discussion about if some of those could just be papers, and we can then decide whether we want to talk about them in meetings, depending on how.
The older people's plan one is Cabinet have moved, this is one I spoke about at the last meeting, where Cabinet have moved the report from November to December so that we have the opportunity to be able to talk
so
about
we'll definitely
it in
do
November.
that.
Yeah. But the others potentially could be moved around.
Okay, all the others we'll try and move around. Okay. There's so much to discuss, isn't there? It's quite crazy, really. But anyway, okay. So are we all happy with those changes to the work plan? Agreed. Fantastic. Okay. The meeting is the meeting about to end?
It can.
Brilliant. So the meeting has ended. Thank you.